this month, I'm speaking to you about another COVID-related project that we had the opportunity to do at NBRDT. And as opposed to using survey data, as I presented last month, the project that I'm talking about today works with specifically administrative data or other population level data sources. So that would include data that might be available on all New Brunswickers, for example. So the project was conceived once COVID sort of hit our province, and NBHRF and NBIF, two funding agencies here in New Brunswick, put out a call for funding for COVID-related research in New Brunswick. And so our application was successful, which is always great, but always tough. And so the project we entitled Planning for Community Resiliency and Recovery from COVID-19 in New Brunswick. So as the title implies, it's really focused here on aspects of the New Brunswick population with the goal of characterizing community level burden of particular vulnerabilities, and by identifying those vulnerabilities and characterizing them, that we might be able to plan for resiliency. So that's where the title sort of provides a scope of what we're talking about today. So as Tracy mentioned, I'm an epidemiologist, but all my research that is done is team-based. And so some of the team members that helped today with the work that I'll present today are Madeline Agramand Alsal, Paramdeep Singh, and Chandy Samajian. These are team members at NBRDT as well.
Andrea, it's Tracy. You might want to just pull the camera back a little bit. It's a little tight.
Okay, sorry. All right, let me see if it's too close. All right. So just to get us started, just a little bit of a context in terms of the pandemic and maybe what that means for this particular research that we're presenting today. So as you're all very aware, the pandemic has had a substantial impact on the daily lives of all individuals, including all New Brunswickers. In particular, we may be uniquely challenged by key measures that have been put in place to really control the spread of the virus, and key measures such as stay-at-home orders. We've been asked to reduce our close contacts, as well as increase our distance from individuals who are not within our household bubble, for example. But these different measures, while very important to maintain the spread of COVID-19 in our population, will have differing impacts on different residents in our population. And some groups that we were specifically interested in exploring, because they may be more vulnerable to these particular consequences that we have to put in place to limit the spread, include several groups. I've mentioned a few of them here, but older adults. So one key concern in the older adult population, not only are they at increased risk for critical healthcare needs, should they be infected with COVID, but also the alternative of thinking about social isolation and aspects and how that might add to a health burden among our senior population. In addition to seniors, individuals who are living with physical health conditions that are predominantly relevant to negative COVID outcomes. So negative COVID outcomes being hospitalizations, ICU admissions, or even mortality. So thinking about specific conditions that predispose individuals to having higher risks. And of course, we can't forget the mental health impacts or concerns as a result of the pandemic, thinking about how the different measures that we've put in place may impact specific populations. And of course, the economic downturn has had quite a substantial impact on most individuals' lives, and specifically individuals who are socioeconomically disadvantaged prior to the pandemic may be at greater risk or have more vulnerability to negative outcomes related to these measures that we've put in place. As we are very cognizant of now, many jobs that allow us to work from home tend to be a disproportionately distributed into specific populations, and those who are socioeconomically disadvantaged tend to be groups of individuals who have positions or jobs that don't allow them to work from home. And so there's additional vulnerabilities that come with some of that. So in order to sort of think about how we might be able to support our population in protecting these vulnerable groups in order so that we can put interventions in place where they may be needed or plan for certain outcomes that might be anticipated, the goal of this project was really to hope to provide these planning tools that will help to enhance the resiliency as we recover from the pandemic, as well as continue on through the pandemic, because as we are all aware, it's not over. So the objective of this particular research that is here today in this presentation was to develop an analytical framework that facilitates the generation of community level indicators that are relevant to COVID-19 pandemic planning and recovery efforts in New Brunswick. So just get into a little bit of the methods. So this is an overview of our research plan. We conducted the research using infrastructure at NBIRDT. So that's the New Brunswick Institute for Research Data and Training. We used an integrated knowledge translation process with stakeholders to identify vulnerable populations, as well as specific vulnerabilities and resiliency factors that relate to predetermined areas of focus, which I'll get into shortly. So the goal was really to use information and input from stakeholders within government, within the regional health authorities, as well as community-based organizations in order to identify what are key priorities and what are things that might be helpful in planning efforts. And so we generated the indicators for this project using that knowledge that we gained from those interactions. Using that knowledge, we brainstormed and researched the literature to identify appropriate proxies or approaches that would allow us to characterize indicators that serve to characterize vulnerability in our communities across New Brunswick. In order to derive the data or derive the indicators for this research, we used data that was available at NBIRDT, and the data that's available at NBIRDT mostly comes from GNB. In fact, a number of the data sets mainly come from Department of Health as well. And so I'll get into a little bit more into that, but as well as some open sources that we were able to identify from the open source domain. Putting all this together in terms of characterizing the indicators, identifying priorities, we then, as a tool to disseminate the knowledge that we gained through this research, is we mapped these indicators at the community level for communities across New Brunswick, with the idea of identifying communities that would have more burden versus communities that would have less burden on specific risk factors or vulnerabilities. So these were areas of focus for the project as we set out to examine. And so we focused them really on potential consequences of COVID-19. And we really wanted to focus in on 5 areas that we identified in advance. And then the indicators that we'll describe will fit or within these 5 umbrellas. So the first is really poor health outcomes associated with being infected with COVID-19. We are absolutely concerned about this because of the capacity of our healthcare system. And so this is really important in order to reduce the impact, health impacts of the virus itself. But the other consequences are related to the alternative approaches due to our restrictions to limit the spread to protect those who are vulnerable to infection, including greater risk of infection in collective dwellings, aspects of social isolation or mental health concerns associated with being sheltered in place, poor educational outcomes due to school closures, financial vulnerability, as well due to loss of employment or precarious environments. So just to give you a little bit of background on what NBIRDT is, if you're not familiar with our work, we are really a research institute that is devoted to objective, rigorous, and evidence-based research and policy program evaluation. And we're mainly housed to really support GNB planning and policy development. So most of our partners that we work with are within GNB or the regional health authorities. The regional health authorities and GNB have provided us with person-level de-identified data, such as hospitalization records or physician billing records that allow us to conduct research. And these data are available for research purposes to anyone in the province, should they go through all the steps in order to gain access. But at NBRDT, we provide that access within a very secure facility, given the nature of the data that we hold, and we act as data custodians. Oops, sorry about that. So we receive data from GNB, from RHAs, from community-based organizations, and we link and we host that, and we provide it for research purposes, but we also link data from other sources such as studies. So several of the Healthy Senior pilot projects will be linking to our data sets as well. So for the COVID project that we did, we really looked at specific data sets and to form or derive our indicators. The data sets that we used for this project are listed here. So they mainly come from Department of Health, Department of Social Development, and ECD. As well as other sort of public sources. So thinking about the Department of Health, mainly focusing on our Medicare registry to identify individuals, as well as household compositions. Some of the health-related data sets that allow us to identify individuals who have specific conditions, including physical conditions or mental health conditions. Social development data really helped us to characterize some of our vulnerable populations. So thinking about income support and our long-term populations, those who are receiving home care, for example, or home support, or those who are living in adult residential facilities or nursing homes. Early childhood education, we have some data from the early years as well as school age, and so we're incorporating that into this research. We were able to use some data that comes from the New Brunswick Health Council that they publish online, from Statistics Canada that's also published online, and Innovation Science and Economic Development Canada was a data set we obtained on internet connectivity. So the strategy of our research was to engage stakeholders, and in order to engage stakeholders, we convened several different opportunities with different groups within GNB and the RHAs. But in order to demonstrate what the work we were doing, we decided to first put out a release in the fall of 2020 that really focused on very high level indicators that gave us a sense of vulnerabilities and the tools that we were hoping to create with this grant that we received from NBIF and NBHRF. And so the first release focused on these 6 indicators in 4 of the areas of consequence I had described previously. And so I'll get into some of these results in just a moment. So the goal really was to derive these indicators, but then using the information that we can obtain from the data we have was to divide the indicators or to characterize indicators at a community level. So the community levels that we chose for this particular project were the New Brunswick Health Council communities. So in New Brunswick, there are 33 of these Health Council communities, and the map here demonstrates those 33 regions. And they all are nested within the zones that we're very familiar with in terms of COVID reporting. And these specific administrative areas are important for Department of Health services as well as for other departments within GNB. But in order to provide information for other departments that we engaged in, for example, with social development has their own regions, but conveniently they fit very nicely into the HCC regions. And so our data are able to sort of inform on different regions for different departments. And we used an analytical framework that is flexible, and it allows us to map sort of different types of geographies. But because this geography in terms of the HCCs allows for 33 different areas, this really was kind of the lowest, greatest level that we focused on, and the other geographies that we've identified are much more larger. And so the idea of being able to characterize differences between smaller areas was really a goal of our work. So just getting into some of the results, I'm going to present first some of the results that came from our first release, and we are just anticipating our second release in probably within the next month or so. And I'm going to get into a little bit of that to give you sort of a heads up as to what to expect that's coming soon. So as I mentioned, the first consequence was negative outcomes associated with COVID-19 infection. So we looked at multimorbidity. So multimorbidity indicates individuals who have more than 2 conditions. So we did not focus on whether individuals just have one condition that potentially predisposes them to increased risk of negative outcomes, but we thought let's identify individuals that have more than 2 conditions. This is something that has been also reported in the literature. We focused in on conditions that were demonstrated in previous studies to be relevant to COVID-19 outcomes. So things like diabetes, things like COPD, and other heart-related conditions, as well as more rare conditions like HIV, for example. And these were included into this indicator. And having one of the indicators would not lead an individual to be identified here, but they had to have 2 or more. And so what's demonstrated on this graph are these health community councils, and the health community councils here are now different colors, and the different colors on the maps represent different levels of burden. So on this particular map, the purple or the blue here represents the lowest level or the lowest burden, whereas the red represents the highest level or the highest burden. And so as we can see, there is a distribution across the province that differs from areas of low or to areas of higher. So we can see that specific areas might have a greater proportion of individuals who have these relevant physical health conditions than other areas. These are estimates of prevalence, so they include everyone in that population and not necessarily indicating the number of people that are in. And as we know, these different areas have different population sizes. So here we see particularly shining through, not in a good way, of course, but that Minto, the Health Community Council of Minto seems to have a highest rate of multimorbidity with relevant physical health conditions. We can see that the northern areas of the province also seem to have higher levels than some other areas that are maybe more populated. And so that provides us with some sense as to where the spread of COVID-19 might be additionally problematic for example, admissions to hospital. So thinking about older adults as being particularly vulnerable to consequences of COVID-19 and thinking about children who attend school and who may have the opportunity to bring the virus home, we decided to characterize households in New Brunswick that identify as having both older adults and children co-residing. And again, the map provides us similar information that we have areas that have lower burden, but areas that have higher burden. And so the goal is really to try to identify where this might be more problematic. For example, if we have several school outbreaks, we might want to close schools in Sussex, for example, because of the higher burden of the population who live in households that have both children and older adults. We also looked at mental health impacts, so different levels of mental health severity we wanted to characterize. These 3 maps here are mutually exclusive. So if you are in C, you are not in B, or you are not in A, for example. So these are unique individuals that make it into each of these maps. A talks about possible mental health concerns. We use data on physician billing services to identify individuals who sought services for psychotherapy or counseling from their family doctor or a psychiatrist in New Brunswick. And so this represents the lowest sort of level of mental health concern, but still potentially individuals who are at higher risk of reaching a diagnosed level or having problematic impacts as a result to the measures we've put in place. So the second map here demonstrates diagnosed. So this is physician diagnosed mood or anxiety disorders. So that includes depression as well as anxiety. And then the bottom graph or map, sorry, demonstrates severe levels or acute mental health concerns, which are actually admissions for a number of different mental health conditions that were identified. And from these maps, we can also see that there's quite a bit of a distribution at the different levels, and that in some areas that there's higher burden, whereas in other areas there are lower burden. But we can potentially see where we might have additional people might be more likely to enter to the diagnosed areas given areas that are more colored in red. So this is a consequence that we thought would be important in terms of thinking about older adults and mental health impacts of social isolation. And we used our data to characterize households that just had older adults living alone, not residing with other individuals. And here we can again see that in the northern areas of the province, where we've already identified vulnerabilities in some of the other indicators, that we do have more of a predominance of seniors who are living alone. Whereas, for example, in the New Maryland HCC, there's, in terms of the distribution across the province, that's the area that may have the lowest number of older adults living alone. Okay, so that was the results that we had included, or some of the results. I didn't present all of them. There was a few of the indicators that I had mentioned earlier that I didn't include in these results sections, but they're all available in our preliminary release, which I've posted the URL here, and you can find through the UNB website. And this first release was a static document. It was just intended for the purposes of being able to demonstrate the tools that we were trying to use and the concept of the indicators that we were trying to develop. As I mentioned earlier, those were 6 indicators at a very high level. And the reason why they were a very high level was because within the NBRDT data infrastructure lab, in order to release data, there's a bit of a process that must be, the data must be vetted and has to satisfy certain criteria. In order to be released, it has to have to avoid disclosure issues, the new data that's released has to be sufficiently different from the old data. So our preliminary release really focused on these high indicators, but we have since been working very diligently on putting together our final release, which includes a larger number of indicators. I was trying to count them, but I think it's like over 100 different iterations. So there's quite a lot of information, contextual information to search through, but we're putting it into a cohesive fashion that will allow users to explore the data interactively online. And so this is just an example of a tool that was created for a research project in the US where they were looking at impacts of obesity. And specifically this map here now takes the maps that I just previously showed you to another level. So here we've got not only a single indicator, but we're able to see where is diabetes highest, where is obesity highest, and where are they both highest. So we can see in the map of the US that areas that are colored in this darkest blue or purple, that those are areas that have high obesity and high diabetes. Areas that are in white are areas that would have low of both of those. And so we can start to see where these vulnerabilities might coincide in particular communities. And so that was really the goal of this research project, was to look at multiple vulnerabilities and how they layer on one another to produce additional burdens on our population. So some of the indicators that I presented to you just now, we've started to look at them in this way, but these are not maps that will actually end up in our final release, only because the way that we are able to access the data is that we're able to look at all these, not all of these, but many of the indicators at the individual level. So this map here just demonstrates the data that I had previously showed you for physical health, as well as older adults living with children. And this provides you a sense of areas that have high levels of physical health, high levels of collective dwellings, so thinking about children and older adults, but also that have high levels of both. So when we looked at physical health, we saw that Minto was bright red. When we looked at collective dwellings, we saw that Sussex was bright red. But now we're getting a bit of a different story. Okay, so we see definitely that Minto remains high in multimorbidity, but in terms of number of children who live with older adults, that level is quite a bit lower. Okay, whereas in Sussex, we know that based on the map that I showed you previously, that we had a high level of older adults living with children, but in fact, Sussex also has a higher level of multimorbidity. So this goes to the point that thinking about interventions or strategies to reduce the impact on the population of exacerbation of infection, that we might want to act differently in different particular areas. So this map looks at mental health and population subgroups of older adults living alone. And so we can here see that the northern parts of the province remain high in terms of both mental health condition and older adults living alone, which is what we observed in the individual maps, but now seen as sort of coinciding. And we can see other areas that may have low burden of both of these conditions. And so interventions perhaps are less needed in these particular areas for social isolation among seniors. And here it also helps us to describe the distribution across the different communities and the level at which some of these communities might be more burdened or less burdened, for example, by different strategies that we may have put in place. So as I mentioned, the final release is an interactive online tool that includes a number of different indicators, all focused within the areas that I've described already. So physical health, mental health, collective dwellings, education, and financial vulnerability. And so I thought I would just take the opportunity to give you guys a bit of a snapshot into what is going to be included in this final release. So that you can see where this information might be helpful in your planning efforts, or just in your informational efforts to try to get a sense as to what is the population in New Brunswick and how do these different factors which are relevant to COVID coincide. So for physical health, I demonstrated or showed you the 2+ relevant physical health conditions. But in addition to having 2 or more of those COVID relevant conditions, we've also described comorbidity at the population. So this includes a number of different conditions that are COVID related and not COVID related. So the idea is it just provides a sense of what the population level burden of comorbidity among adult populations specifically. We also characterize a measure or an indicator for level of frailty. Frailty is much more common as individuals age. So frailty was just characterized in older adults, and for frailty we focus specifically on those individuals who are over the age of 75, only because frailty and death are closely correlated. In addition to these negative, I guess, physical health indicators, we also wanted to just look at sort of preventative strategies in the population or activities in the population. So we were able to use our data to characterize levels of immunization for specific vaccines. We focus specifically on flu vaccines, influenza vaccines, as well as pneumonia vaccines. And so just to get a sense as to what might be the potential uptake of COVID vaccines in the population as well, but also a level of protection from viral infections and bacterial infections, of course, with pneumonia. So these 4 conditions or indicators that we had characterized are able to be described the burden at the population level on their own. But in addition to thinking about how they are distributed individually, we also wanted to sort of look at how they're distributed in relation to different aspects. So thinking about maps like this, where we can look at 1 or 2 or more indicators together, we are also really interested in understanding among individuals who have 2 or more relevant conditions, what proportion of them are dealing with mental health conditions, because that would create or provide a sense of an additional vulnerability at the population level. Among individuals with relevant conditions, I've demonstrated one example looking at older adults and children living in collective dwellings, but we also have other types of indicators at the collective dwelling level that we'll be describing in relation to physical health. Other things like financial vulnerability and how that relates to physical health. The measures of financial vulnerability that we focused on look at material deprivation specifically. And so thinking about areas that have high burden of physical health, negative physical health conditions, and a high burden of, say, economic instability or housing, then that could potentially highlight additional areas that are potentially vulnerable. Age groups, we also looked at children, adult population, as well as the seniors. Vulnerable groups, we focused in on specifically those on income support, those among the long-term care population, so receiving home support or receiving or living in an adult residential facilities. In terms of access to healthcare, we also thought that that was an important stratifier for our indicators. And so this includes several different aspects of healthcare access. So one clear, obvious one was the density of GPs in communities across New Brunswick. But we're using the data that we have access to. We were also able to characterize sort of movements within different health regions. So we wanted to characterize thinking about access to healthcare. We know in New Brunswick that it's potentially geographically dispersed depending on where you live. And so thinking about having to travel to a different health region than you live in is one of the things that we characterized related to health access. We also looked at the health access in terms of previous admissions for certain conditions that represent poorer, I guess, community care. So thinking about areas that might have higher levels of individuals who are admitted to hospital for specific conditions that are treatable in the community, so through primary care, that might highlight areas that are potentially increased vulnerability should COVID impact that community. So thinking about collective dwellings, I've mentioned seniors and children living alone, but we also really interested in household densities. So the number of individuals living in a particular household, as well as locations of nursing homes and adult residential facilities. And again, I've listed here some of the examples of things that we have stratified these indicators by. So in terms of mental health or social isolations, we looked at severity of mental health concerns. So as I demonstrated earlier in the presentation, but for several of the indicators, we've combined those because it demonstrates the level of mental health burden at the community level, but also thinking about how some of these different factors interact with individuals who live alone, for example. So poor educational outcomes was another consequence that we were really interested in examining. We were able to use our early years evaluation data at NBRDT, which includes preschool evaluation or entry into kindergarten, and characterizing the level of these children and different communities across New Brunswick. And that includes preschool. And then we also are looking at standardized testing scores for schools across New Brunswick in the different school districts as well, and interested in characterizing how these particular factors relate to different levels of internet connectivity. So for example, are areas that have high level of children who are not meeting the standard for their early years evaluation, so meaning that they've got more, they need more, they have more needs, are those areas that would have potentially less internet connectivity or more internet connectivity. As same thing with standardized testing scores, thinking about schools or districts that might have, or areas in schools in areas that would have a lower proportion of students who pass standardized testing scores, and what that might mean relative to different characteristics, such as internet connectivity. As we can imagine, children who need to access the internet for school resources and are in areas that have less internet connectivity and more needs, that might be particularly vulnerable. So the last consequence was financial vulnerability. These are the indicators that we looked at. Specifically, these are available through Statistics Canada, and these data were used at the community level, thinking about material deprivation, specifically components that build into that are residential instability, economic dependency, and situational vulnerability. There's also an ethnocultural part of this index, which is included in the composite index, but we didn't look at it specifically here for New Brunswick, just because of the composition of our population, and we didn't feel that it was variable enough. And so here I've noticed that I didn't change this, but that these indicators that we have stratified are also in line with some of the other things that we've looked at previously. All right, so I'm going to finish up here, but overall I've sort of provided you with a bit of a snapshot of what we have in our first report. And again, like I said, our first report is available online. We're happy to share it with you, and if you use it for your planning purpose, that'd be great. We really hope that these population-based indicators that characterize communities across New Brunswick can be used to enhance resiliency. So in being able to plan for vulnerabilities that we may be able to overcome them. So thinking about helping to limit the spread and exacerbation of infection in those most at risk. So I was particularly happy, not happy, I guess is the wrong word, but to see that in the Edmonton area that the health region was in lockdown, but certain health community councils in that health region were not in lockdown. So thinking about the data that we've generated and how that might help to inform certain efforts there as well. If there's areas that have high burden of those physical comorbidities, for example, that might be additionally problematic in deciding whether to open or close that particular area. And some of the data we provide can help support some of that planning. Also thinking about identifying at-risk groups that are mostly impacted by the measures to limit spread might lend themselves to opportunities to intervene or to establish structures or policies that might help certain populations. So these population at risk indicators also provide contextual information. So there may be many different types of indicators that are relevant to one's own planning, that they can provide that contextual information that might help with resource allocation. We know, and resources are going to continue to get scarce. And so the idea of thinking about where are those best used, some of the data that we provide can hopefully help to inform those decisions. And so we really wanted to be able to highlight those vulnerabilities and thinking about where and the interventions may be needed. So our final release will be completed shortly, but it'll be freely accessible online. And I think that one of the things that I would hope is that we could share amongst the group, Tracy, here, once we do have a link. It's going to be a website. And so the idea would be you could access that at your own leisure and explore the different indicators we're putting it into a cohesive fashion so that it's like a story that you're going through, but that you're also able to access the specific information that you would need for your planning purposes as well. So I would like to thank you for taking the time to join us today. I'm open for any questions at all, and of course also acknowledge our funding bodies. So thank you.